Hello, I'm Enrica Orsini, Education Scientific Lead for EHA, and I'm here today to speak with Professor David Rees about acute chest syndrome in sickle cell disease. Professor Rees, if you want to introduce yourself.
I'm David Rees. I'm a paediatric haematologist at King's College London and have an interest in sickle cell disease.
Well, so to start with, do you want to give us an overview of what is acute chest syndrome in sickle cell disease and why this is important?
Well, it's an important complication. It's probably the second most common reason people get admitted to hospital in most countries, and it's associated with a significant number of deaths, and there's quite a lot of extra time in hospital, and potentially quite a severe complication, and does require quite specific management and doesn't always get managed in the best possible way.
There is some difference in epidemiology in children, adults. It's more in a specific category of patients.
Yes, there's lots of problems with, although it certainly exists, there's lots of problems in general with the defining what it is, and it does vary from being basically an infection in the form of pneumonia to being mostly to do with vaso-occlusion and sickling. And in general, in young children, it's often mostly an infective complication, but there's always some degree of sickling. So you don't tend to refer to pneumonia, say, in children with sickle cell disease. You'll tend to call it acute chest syndrome. And as you get older, the proportion and the relative importance of infection probably gets less, and it becomes more of a vaso-occlusive complication, mostly to do with sickle cell disease. The pathology is complicated, and there's lots of other factors going in, and once it starts, everything goes wrong. But it's usually either triggered, in most children, it's triggered by infection, and vaso-occlusion then becomes important on top of the infection.
So, speaking about the pathophysiology, if I understand well, it starts with an infection or an episode of vaso-occlusion, and this is going to target the lungs.
Yeah, I think it becomes a vicious circle. So, in simple terms, and probably in real terms as well, then you get a bit of infection in the lung, and that bit of lung becomes hypoxic, short of oxygen, and so you get vaso-occlusion and sickling in that bit of lung, which sort of further makes it more hypoxic, and it makes the infection worse, and the infection makes the vaso-occlusion worse, and so you very rapidly get a sort of upward spiral of damage to the lung, with the sickling triggering the infection, and the infection getting worse because of the sickling. And in addition, there's other factors involved, like hemolysis and the release of heme, which is very damaging, and changes in the immune system. And there's a feeling that in some people you get infarction in the bone, and that releases fat, which then lodges in the lung. So fat embolism is part of it. So it's a kind of complex mixture of things going on, but because the lungs are critical, and with the source of all reducing the oxygen in the lungs, has consequences for the lungs very quickly, but also for the whole body. So at its worst, it spirals into sort of multi-organ failure and potentially death.
I see. So it is a systemic reaction that is...
Well, it starts in the lung, and the lung...
Yeah,
but obviously, if you become short of oxygen, that has consequences for the whole body, particularly if you've got sickle cell disease, but then you get vaso-occlusion all over the body and in other organs as well.
And from the symptomatologic point of view, these patients, how they could appear, how can be diagnosed, and what should be the thing that let you think something like this is going on?
Well, there's various definitions, and none of them are entirely in agreement or precise, but they all involve some degree of abnormality on chest X-ray or chest imaging. So you have some degree of consolidation in at least one sort of segment of the lung, and in addition to that, you need other lung symptoms such as a cough or fever or fast breathing or chest pain, typically, or a combination of those. In about half the cases, it happens when people come into hospital with one problem and the chest syndrome develops on top of it. So they might come in with pain in the leg, and then they're in hospital, and the chest syndrome develops whilst they're in hospital, partly because they're in bed and they're having analgesia, so they don't breathe deeply. So it becomes it's a mixed picture really. So the difficulty is when people come in knowing really when to do a chest X-ray or not. So you can't X-ray everyone in the sense that you expose people to radiation, and that if people are going into hospital, 2 or 3 times a year in a lifetime, they end up having hundreds of X-rays if they're X-rayed every time they come in. So you have to have some key guide as to when to perform X-rays on people, and that would typically be those symptoms of cough and fever and chest pain or breathlessness. But it's not entirely precise how you define it, and some people might be missed with it.
Yeah, exactly. That was the impression. Not easy to find a pathognomic, very precise symptom that can.
It is, and it's easy to miss it until it's very late, and the person is very ill, and there's a feeling that by identifying it earlier and treating it early, then the outcomes are better.
And coming to management, exactly how is the management of these patients?
Well, there's no specific management, and management hasn't really changed or improved very much for a long time. When I had to do the slides for this, I don't know if you want to include this, but when I had to do the slides for the talk, I had slides that I did from about 10 years ago, and in fact I thought, I can update it, but in fact going through it, there was very little that I could update. There's very little progress happened. But the basis is to have, people need good medical care, and as I say, infection is an important component of all of it, so people should pretty much always start antibiotics, and if the oxygen levels are low, they need oxygen support, and they need good fluid balance. Often they're ill and they can't drink very much, and people with sickle cell disease get dehydrated easily, so they need good hydration, but not too much fluids. And there has been a trend to give people huge amounts of intravenous fluids, which causes problems in itself. People need pain control, and so that they can breathe deeply. But again, it's a balance in that if you give people too much analgesia, they become sedated and they breathe less deeply, and it becomes part of the problem. Blood transfusion is thought to be quite important. Certainly if someone's ill and deteriorating, the hemoglobin is falling, then early blood transfusion seems to improve outcomes. And when people get very sick, then an exchange transfusion is often performed. Exactly when and how you perform the exchange transfusion, again, isn't very well defined. There's no specific. There are trials of corticosteroids.
That was my next question. The corticosteroids
Well, it is linked to asthma, certainly, and in some people if there's any evidence of reversible airways, then people go on bronchodilators. There is a trial in children saying steroids improve outcomes in acute chest syndrome, but they're often not used, and a lot of guidelines don't even mention them because there are side effects of steroids, and when they're stopped, people tend to get rebound pain and sometimes more serious complications like high blood pressure or even cerebrovascular disease and stroke. But I think they're probably underused, and we use them sometimes. They do make quite a big difference. They can stop when someone's deteriorating, they can sort of reverse that and stop them needing to go on to needing full ventilatory support and ITU support. And I think, I'm not really sure why they've been neglected so much, that the steroids do work, but you have to be careful, and sometimes people get pain when they're stopped. But potentially having rebound pain is better than ending up on intensive care requiring ventilation. And there is a trend to give very high dose of steroids for hemolytic complications in sickle at the moment. So I think it's something to think about. It's definitely not a wonder option. The basis is they need good medical care. They need people to follow them closely and support all their vital functions, and probably if they're getting sick, transfuse them, and they reduce the amount of sickle in the blood. Sadly, there's no specific treatment for it.
No specific treatment for a non-specific disease?
Well, for sickle in general, there's not. But if there's acute chest syndrome, there's no drug you can say this is, apart from steroids, which is, as I said, is debatable, then there's no specific drug that's been shown to change the natural history to improve outcomes. But there's been no trials of any drugs, so that's one reason why that might be the case. You can prevent acute chest syndrome quite effectively, and hydroxyurea has been shown to reduce the frequency of acute chest syndrome. Sorry?
I mean, reduce significantly.
Yes, and we've seen a change in our practice over the last 15 years. We see far fewer cases of acute chest syndrome now because far more people are taking hydroxyurea. The second thing that has been shown to help prevent problems is a thing called incentive spirometry. And as I said, a lot of the cases, nearly half, happen in people already in hospital. And if those, again, this is in children, but is still used in adults, if those children are encouraged to breathe deeply when they're in hospital, then that's been shown to reduce the frequency of acute chest syndrome developing. And the way that's done was with a thing called an incentive spirometer, which is like a thing used for asthma, really, to measure how fast the airflow is. And children, in fact, suck on it. They sort of breathe in deeply using one of these spirometers twice an hour or maybe 4 times an hour by still in hospital, and that's been shown to reduce the frequency. And it's quite a nice thing, so it's quite easy to do. And it means, if nothing else, someone goes and talks to the patient once an hour and makes sure that they're still okay.
Perfect. Thank you very much.
Good.
Thanks.